You know, this quote is interesting too. You know, he said managed healthcare was a great idea when it first emerged, before the term got hijacked by insurance companies that claimed to manage care, but in many cases only managed costs. Going back to my introductory remarks, remember John Q. Public, and you know, the guy who shot himself in the hospital, you know, in the movie, you know, so that his son could have his liver for the transplant. You know, that really was the legacies of the 90s. And what Dr. Berwick says about that is, you know, that the HMOs failed because they were managing only the money. And you need this, again, this integrator who's going to accept responsibility. So you have the global budget, but you also have this responsibility as the integrator for the patient population. And the other thing that Dr. Berwick talks about a lot is cooperation across communities as the hallmark of reform. The one that that we hear talked about a lot, and it's really interesting because I know Dr. Jeff Thompson from Gunderson Lutheran. Gunderson Lutheran gets talked about a lot, and La Crosse, Wisconsin gets talked about a lot. Now, I don't know if any of you here know what the per Medicare beneficiary per year amount is, you know, in Joliet or in DeKalb. Do people know what the amount is, the number? Because if you go on Dartmouth Atlas, there is a number. There's a number. And so in Milwaukee, it's about $8,000 per Medicare beneficiary per year, right? In La Crosse, it's $6,500 per beneficiary per year. Now, and I think if you go to Joliet, I think it's $9,000. You know, it's Illinois, because I think it's a little less consolidated marketplace. You see the Walter, do you know, nines and tens? So, you know, there's a lot, if you look at it from the Medicare program's perspective, a lot of, there's some good examples, some bad examples. This goes back to Atul Gawande and the articles that were in the New Yorker right when Obama was elected. So anyway, and if you go to Gunderson Lutheran in La Crosse, Wisconsin, I think you're going to get very good care, but you're going to see a lot of PAs. You're going to have trouble seeing that doctor. We just had a friend whose daughter had sort of a serious head injury, and you know, we were talking Wednesday night. She said, "My gosh, you know, I went to Aurora in Milwaukee and we saw a doctor, and her doctor's caring for us, and we're now, you know, in relationship, and all this is great." Well, in La Crosse, she couldn't get beyond the PA, and so that was, I think that's sort of the tension. So here he is, Elliot Fisher, the father of the ACO concept. He talks about networks of physicians and hospitals, fully integrated health systems. The key ingredient is the ACO must be the integrator. He talks about that again, responsible for patient population. He envisions that at some level you're going to have the payers at the table, and he envisions the ACO building on current referral sources and current patterns of care, not being completely made new out of different relationships. The rulemaking on ACOs is due out soon. We haven't seen it yet. We do know there are demonstration projects out there, and there are learning collaboratives. We also know that there are NCQA standards for ACO development. And as one of the takeaways today, and I'm not going to go into the NCQA standards, but you know, thinking through those standards and how your health system can embrace those and start to work down that road, that to me, again, is a kind of a tangible thing. Also, I've mentioned that AHA has case studies too on rural markets. They've taken rural markets and urban markets and tried to put sort of a picture together of what the ACO should look like in these different markets. And I think we're all really incredibly sensitive as an industry to the fact that Geisinger, Intermountain, Mayo, that's not what the model is everywhere. And many places physicians are not completely employed. So there are some examples out there which I think are good, and again, I'm talking good first steps, to try to visualize what could be in your market given your unique situation. This guy we put in here because he said the term that I think a lot of people use, we're guilty of business model malpractice on a grand scale. And he goes on to say, which I think is really interesting, Dr. Christensen from Harvard, the type of competition that brings down prices is disruptive innovation. Disruption in healthcare entails moving simplest procedures now performed in expensive hospitals to outpatient clinics, retail clinics, and patient homes. So Chris Anderson and I did a project. We were out in California, and we were helping to create a medical city this last year in California. It was kind of a new conceptual healthcare community in Riverside, California. And there was a lead doctor, and we had many good philosophical discussions with him. He was a 100-person multi-specialty clinic, and we talked about in our old vernacular how we wanted to put things near the hospital. Maybe we could get provider-based reimbursement. Maybe we could get onto the hospital's managed care contracts, get better per unit. And he was not interested in that a bit. He said, I do not want any hospital. I don't want cancer care to be a hospital, chemotherapy to be a hospital-based service. Are you crazy? I manage a CAP. I need that to be in the physician's office. So, you know, I think in some areas you're seeing redesign of services around cheaper services, not a collective desire to get a bigger piece of the Medicare, Medicaid dollar, private insurer dollar, which to me is a little bit of a paradigm change. We heard a strategist at the Wisconsin Hospital Association annual meeting talk about the same thing, and he was challenging the health systems in the room to rethink are they a diagnostic center? Are they really a treatment center? And what are they a treatment center for? What can they do well, and what should they not do in their community? And that, I mean, it raised, I mean, I think people came out of that meeting kind of feeling a little bit down in the mouth, but that really was the dynamic he put out there. And I think when you think about managing the global budget, you know, that's certainly going to have to be consideration. And so the Affordable Care Act, I always say this, not everybody hates it. You know, there are parts of it that people dislike, and parts of it I dislike. But people, when they gravitate to it's really a two-pronged bill. You know, it's an insurance coverage reform bill, and it's a delivery system reform bill, or law. And people really dislike, when they dislike it, they dislike universal coverage and the price tag. But they don't dislike necessarily insurance reform. And we saw that, I saw that yesterday, I think, in the House repeal. You saw Republicans saying, okay, I wasn't really going to vote for repeal, I was going to vote for repeal and replace. What are we replacing it with? Because when you talk to Republicans, and they will say, we don't think the health insurance system was operating appropriately in terms of some of the exclusions for pre-existing conditions. I don't know any, I've never talked to anybody who thought that exclusions for pre-existing conditions was really a good idea. So, you know, people just philosophically believe that if you buy the insurance, you know, you should be able to buy insurance that should cover you. So, you know, and at a cost that everybody else is paying. So insurance coverage reform is something that has some broad-based support. And even though people, the Republicans, you know, you see these states, in Wisconsin, Illinois maybe is grappling with it too, health insurance exchanges. What are we going to do? Are we going to do the Utah model? Are we going to do the Massachusetts model? Are we really going to embrace health insurance exchanges? Well, okay, health insurance exchanges is an idea that came out of the Heritage Foundation. It is not necessary, it has some bipartisan support. Now, if you talk to Paul Ryan's office, they'll tell you, well, we want it to be voluntary. Yeah, that's right. And if you talk to the Democrats in Congress who were supporters of the ACA, they say, well, what we wanted was we wanted the public option. So, folks, the fallback, the compromise was state-based exchanges. And what the Democrats, who were not confident that the states would actually enact exchanges, did is they said, all right, if they don't enact the exchange before 2014, we're going to take it over. The feds will take it over. That was the compromise back to the liberal Democrats that wanted the public option. So when you think about health care reform, you know, and I've talked to our state leaders, and I said, you know, think about how you use that health care, how you use the health insurance exchange. Don't think about it as a mechanism for just a growth of government. Think about it as potentially a way that individuals and businesses and even the state can buy health insurance in a more coordinated, consistent fashion. Then you look at system redesign, the healthcare system redesign, which is sort of in the lower half of our chart up here. You know, I know for a fact, working with providers, that efforts have been underway for the last 10 years and tremendous resources devoted to care redesign. I think it's one of the finest things the industry's ever done, because there's really no incentives for it, you don't get paid for it, and it's out there. And what you see is that the regulators and the payment mechanisms haven't caught up with the system's willingness to embrace redesign. So, I was at a meeting at the HA, and now it's probably 4 years ago. Kevin and I were sitting in the audience, and there was some doctor who stood up, and it was the end of the Bush administration, and the acting CMS administrator was talking, and the doctor in the back of the room, who was obviously a hospital employee, but a physician, said, "When are you going to design payments that reward us for all the quality and care management and all the changes we're making?" And this Kerry Weems, who is obviously just the fill-in guy, goes, next question. And so we're still waiting for those payment reforms to come to help pay for the redesign. And so I think everybody knows that this has got to happen, and industry has embraced it. So constitutional challenge, is that going to prevail? Who knows? But remember, where the constitutional challenge everybody believes has the most chance of prevailing is on the individual mandate and the tax associated with the individual mandate. And it's a Commerce Clause. It's a question of the Commerce Clause and the scope of the Commerce Clause. Get right down to the heart of it. Commerce Clause allows the federal government to regulate interstate commerce. Very hard to make the argument, health insurance, health care is not interstate commerce. Very hard. What people who are, supporting the overturn of the law say is, yeah, but this is more than we've ever asked, because what we're saying in this particular law is that individuals have to buy something. We've never said through the use of the Commerce Clause that somebody had to buy something. Now remember, lunch counters and integration, yeah, we said people could go to places of public accommodation, and that affected federal interstate commerce, but we never said you have to buy something. So that's the nature of the challenge. And the cases that people throw up that say, they're very different from this healthcare argument. They have to do with, the expansion, whether you carry a gun at a school, whether the federal government can regulate that. So the cases where actually there's been, the brakes put on the Commerce Clause and its use to govern interstate commerce are not like the healthcare debate. So I was at a American Bar Association summit on healthcare probably right before Christmas, and the speaker asked who in this room believes that it will be overturned, and I think it was like 3 of us that put our hand up. And then he asked who thinks it could be overturned entirely. No one had their hands up. So I think, and if it gets overturned, how are we going to replace it? It's going to be it's going to be a monumental job for our Congress, because you can't knock out coverage expansion and have the rest of the bill work. So we've got ourselves a real mess, whether it's overturned or whether it's not. And I think that the U.S. Supreme Court denied cert. You're going to have to see a couple of, why are they going to embrace this messy thing? They're going to wait until, there's more guidance, I would think, among the district courts before they embrace and really try to take the bullet in unraveling whether this is constitutional or not. So I think it's important to understand the environment. I think and I want to focus in, just before I leave this slide, on the exchanges, and I want to highlight one last point, which is patient choice is essentially inconsistent with coordinated care. So how do we get consumers to choose a plan and at the same time choose a contracted group of providers? And I think California's been ahead of the marketplace in this arena. It's really consumer choice right now. For me, the way to think about this is consumer choice kind of in 2 distinct concepts. One is health plans that offer distinct provider networks where individuals use, personal funds, and they buy up to the right what they want in terms of the provider group that they feel comfortable with as a network. Or we've got consumer choice that is evidenced by or demonstrated by patients being enrolled in PPOs and making decisions at the point of service or the point of care as to what provider they want to access. That's really what we're talking about here in terms of choice. This is my last slide before I turn it over to Carolyn Booty. There's there's been a lot going on. The industry's been embracing a lot of care redesign, but there's also been a lot of impetus from the federal government in different kind of mechanisms. We've been seeing this encouragement to create new delivery organizations. We've tied payments to bundles rather than and episodes rather than individual units. We've got the comparative effectiveness research that has been funded in the Stimulus Act, which is intended to try to propel evidence-based medicine and get the right care design messages out to health systems across the country. We've got some payments that are tied to patient outcome. We actually, as an industry, got stimulus dollars. We did in the road builders. Our stimulus dollars were for healthcare information development and incentives. So you've got a lot going on in bits and pieces to propel this redesign. And with that, I'm going to turn it over to, I'm sorry. Carrie.